Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're tackling hypertrophic cardiomyopathy, a condition that's often asymptomatic but carries a significant risk for sudden cardiac death in young athletes and adults. We'll break down what causes hypertrophic cardiomyopathy, how to recognize it, and what you need to know for both clinical practice and PANCE or PANRE prep. Let's get into it. Starting off with some basic pathophysiology, hypertrophic cardiomyopathy is a genetic cardiomyopathy which is characterized by an asymmetric increase in thickness or hypertrophy of the left ventricular wall. Hypertrophic cardiomyopathy is caused by various gene mutations affecting the contractile components of the heart known as sarcomeres. It is the most commonly inherited cardiomyopathy. The hallmark feature is left ventricular outflow tract obstruction, which impairs blood flow from the heart to the rest of the body, especially with exertional activity. Mechanisms of left ventricular outflow tract obstruction are due to septal hypertrophy narrowing the cavity space and systolic anterior motion of the mitral valve, leading to turbulent flow and increased pressure gradients. This can result in diastolic dysfunction, myocardial ischemia, arrhythmias, mitral regurgitation, and sudden cardiac death. Who does hypertrophic cardiomyopathy affect? It is relatively common, affecting about 1 in 500 people, though newer data suggest it may be closer or perhaps even greater than 1 in 200. This is due to newer imaging techniques allowing increased recognition. It's an autosomal dominant disorder, meaning it runs in families, and is a leading cause of sudden cardiac death in young athletes. There is a higher prevalence in men, and patients usually present most commonly in their 30s. Hypertrophic cardiomyopathy has a wide spectrum of clinical presentations. Many individuals affected are asymptomatic throughout their lives. However, for some, typically during adolescence, unfortunately, sudden cardiac death is the first symptom. The most frequent symptoms are dyspnea on exertion and chest pain. Patients may also experience palpitations due to arrhythmias like atrial fibrillation or ventricular tachycardia, presyncope or syncope, particularly during or immediately following exertion, and fatigue. As far as the physical exam, persons with minimal or no left ventricular outflow tract obstruction may have normal or nearly normal physical examinations. However, the two most common systolic murmurs are related to left ventricular outflow tract obstruction and mitral regurgitation. The murmur heard with left ventricular outflow tract obstruction is a harsh, crescendo-decrescendo systolic murmur heard best at the apex and left lower sternal border, which increases with the strain phase of Valsalva or standing due to decreased preload, and decreases with squatting. Basically, if you increase the outflow obstruction with the Valsalva strain or standing, the intensity of the murmur increases, and if you decrease the obstruction, then the intensity decreases. The diagnosis is primarily made using echocardiography with Doppler, which assesses cardiac size and structure, systolic and diastolic function, and presence and severity of left ventricular outflow tract obstruction or mitral regurgitation. Findings suggestive of hypertrophic cardiomyopathy are asymmetric thickening of the left ventricular wall, often involving the interventricular septum, and the diagnosis is made if a maximum wall thickness of greater than 15 millimeters in adults is present. Other helpful tools include an electrocardiogram, which should also be done, but abnormalities are not specific to hypertrophic cardiomyopathy. The ECG may show left ventricular hypertrophy, prominent abnormal Q waves, or arrhythmias. Given the prevalence of a lack of symptoms, physical exam and screening of all athletes annually during pre-participation is essential. History and physical exam findings that require further investigation include unexplained chest pain, shortness of breath on exertion, syncope, palpitations, family history of hypertrophic cardiomyopathy or sudden cardiac death at an early age, or a systolic heart murmur. Now, let's move on to the management. The management depends on symptoms, left ventricular outflow tract obstruction, and its severity and risk of sudden cardiac death. Asymptomatic patients are observed and have periodic echocardiography. For symptomatic patients, beta blockers are first line. They slow the heart rate and reduce the left ventricular outflow tract obstruction. For patients with refractory symptoms, options are additional medical therapy or septal reduction therapy, such as surgical myectomy or alcohol septal ablation. And lastly, an implantable cardioverter defibrillator, or ICD, should be considered for high-risk patients, such as those with a history of sudden cardiac arrest, ventricular arrhythmias, or a family history of sudden cardiac death. Now, prevention focuses on risk stratification for sudden cardiac death and lifestyle modifications. Patients need to avoid competitive sports or intense exertion. Control of blood pressure and arrhythmias is necessary, and genetic testing is indicated if familial hypertrophic cardiomyopathy is suspected. In addition, in patients with symptoms attributable to left ventricular outflow tract obstruction, healthcare providers should counsel patients to maintain hydration during activities like exercise or outdoor pursuits, or illnesses such as diarrhea or fever that may lead to dehydration, and to avoid treatments that decrease preload or afterload. Common treatments that may worsen left ventricular outflow tract obstruction include diuretics, vasodilators, ACE inhibitors, and angiotensin receptor blockers. Now, let's talk book med versus street med. Textbook medicine says all patients with hypertrophic cardiomyopathy should be identified early, screened, and monitored. But in real life, many patients don't know they have it until a cardiac event occurs. Young athletes often ignore mild symptoms, and clinicians must have a high index of suspicion, especially in patients with exertional syncope or unexplained dyspnea. Now, before practicing some questions, here are some clinical pearls. Number 1. Hypertrophic cardiomyopathy is the most common cause of sudden cardiac death in young athletes. Number 2. Listen for a systolic murmur that gets louder with Valsalva or standing. Number 3. Beta blockers are first line for symptom relief and obstruction reduction. Number 4. ICD placement is recommended for high-risk patients to prevent sudden cardiac death. And number 5. Exercise restriction is critical in patients with severe hypertrophic obstructive cardiomyopathy. All right, let's get some practice in. Question 1. A 25-year-old man collapses while playing basketball. He has a history of occasional palpitations and dyspnea on exertion. His father died suddenly at age 40. Physical exam reveals a systolic murmur at the left sternal border that increases with Valsalva. Which of the following is the most likely diagnosis? Is it A. Hypertrophic cardiomyopathy, B. Aortic stenosis, C. Dilated cardiomyopathy, or D. Myocarditis? I'll give you a couple of seconds. If you chose A. Hypertrophic cardiomyopathy, you are correct. The combination of exertional collapse, family history of sudden death, and a murmur that increases with Valsalva strongly suggests hypertrophic cardiomyopathy. Aortic stenosis would present with a murmur that decreases with Valsalva, and dilated cardiomyopathy typically presents with systolic heart failure. Question 2. A 50-year-old woman with hypertrophic cardiomyopathy presents with dyspnea on exertion and chest pain. She is not taking any medications for this. Echocardiography shows severe left ventricular outflow tract obstruction. Which of the following is the most appropriate next step? Is it A. Start a beta blocker, B. immediate catheterization with stent placement, C. Implantable cardioverter defibrillator placement, or D. IV fluids and high-dose diuretics. If you chose A, start a beta blocker, you are correct. Beta blockers are first line for symptom relief and left ventricular outflow tract obstruction in hypertrophic cardiomyopathy. Stent placement is for coronary artery disease, and ICDs are used for high-risk patients with arrhythmias, prior cardiac arrest, or family history of sudden cardiac death. Lastly, high-dose diuretics can worsen outflow obstruction due to the volume depletion. Great job! That wraps up today's episode on hypertrophic cardiomyopathy. If you learned something new today, make sure to follow and subscribe to the Pro PA podcast for more high-yield content. And as always, this is a Pro PA podcast where future pros in medicine are made. See you next time.